everyone, and welcome to the final merit rounds of the academic year into our second hybrid rounds. If you're joining us in person, welcome to all of you. It's great to see you in person. If you're joining us virtually, it's great to see you, I think, because I can actually see you. So we also appreciate that you can join us virtually. Before I introduce our speaker for this May rounds, I just want to remind you of the next and final important date in the academic calendar of the 21-22 year. That's Norman Education Research Day. We will be joined by Dr. Andrea Gingrich, who will deliver the plenary address, and we'll conclude that day with Dr. Gingrich, as well as Dr. Asai and Dr. Tavares joining us locally and from the University of Toronto, as well as the University of Columbia, or the University of Northern British Columbia, for a plenary discussion. In between those two sessions, we will have all of the rich, engaging, very thoughtful education scholarship being conducted by you, being conducted by peers and colleagues, and being conducted across Faculty of Health Sciences. So we welcome you to join us in person for the research sessions, but by virtual connection if you're not able to join in person for the opening plenary panel. You can find lots more details about that at merit.master.ca. If you're new to Merit and you don't know who we are, you can find more information at the same web address. We welcome you to be part of this community. And now, it's my great privilege to introduce our speaker for the final Merit rounds of this year, Dr. Elif Bilgic. Dr. Bilgic is a new Merit scientist and a faculty member in the Department of Pediatrics, having joined us now quite 3 months ago. She completed PhD training in education research with a subsequent postdoc in the Simulation Center at McGill and a subsequent CIHR postdoc. She has a very emerging and thoughtful and engaging program of research around simulation and around assessment. I don't want to steal too many of her punchline, but she's going to introduce us to her program of research that continues here at Merit. We're really fortunate to have her as one of the newest scientists as part of our team. And we welcome you to engage and meet with her in person or virtually at our subsequent Merit events. So I'm taking up too much time. I'm not here to hear about Merit, we're here to hear about procedural training and assessment, and to hear from Dr. Bilgic. Dr. Bilgic.
Okay, well, thank you very much for the introduction. It's really an honor to be here and present some of my work in terms of my experiences, but also sort of my future initiatives and interests within the field. In terms of disclosures, I just wanted to say that throughout the talk, I will be talking about some of my previously funded projects, but also some of my current memberships and future/pending grants and partnerships. You will see the logos on the slides that correspond to those, so just keep that in mind. In terms of the outline, I will be first briefly introducing you to procedural skills, and then talking about some of the domains of competence that are important for procedural skills training and assessment. And at the end, I will be sharing with you some of my past experiences, but also current interests and future directions. As Jonathan very nicely mentioned, I do come from a specifically a surgical education background. I have my graduate work, my postdoctoral work in the Department of Surgery. So a lot of what I will be talking about, there will be quite a few references to the surgical field. But I think when it comes to procedural skills, because surgery is very much really procedure focused, I would say more often than not. I think we can really use surgery as a reference point. So, but as currently I'm in the Department of Pediatrics, I think there's still a lot of overlap between surgery and pediatrics and other specialties that have procedural components to them. So I will be sharing with you some of my surgical education experiences and overlapping that with pediatrics and other specialties. So I think the first, I do want to introduce, what is procedural skills, and you might come across quite a few different definitions of it. But I found one definition that I think it makes sense. It gave a nice overview of what procedural skills really is. So by definition, we can say that procedural skills do involve both mental and motor skills. Ultimately, the goal is to perform a manual task. You have both the technical component of it, so how to actually technically complete that procedure, but also the knowledge that is required to be able to complete that, and the decisions that you have to make along the way. And procedural skills, as I mentioned, is an important component of quite a few different specialties. And these are just some examples. At the top, you see EPAs that were sort of focusing on procedural skills for pediatrics. And you will see that Royal College has said that these are the procedures that are important for a pediatric resident to be competent at by the end of their residency. And at the bottom, you see an example from general surgery. But this is true for emergency medicine, internal medicine, amongst others. Now, we know that procedural skills are important. We have seen that in the literature. We know that it matters that residents, by the end of their training, that they are competent and that they are able to independently and safely perform these procedures. But why is it exactly important? Why do we care about procedural skills training and assessment? So this paper is not that old. I think it was published in 2013 or 2014, but it was a landmark paper. When it was published, I think everyone was talking about it. Because the idea is we assumed and we thought that the way a surgeon performs in the operating room, that should translate to their complication rates. But we didn't have concrete evidence that we could cite. So this paper really brought that to light. And I would say, and it was a simple enough study design, but it was a very powerful one. Now, the paper is called Surgical Skill and Complication Rates After Bariatric Surgery, and it was published in the New England Journal of Medicine. Now, ultimately, they had 20 bariatric surgeons submitting one video, and the video was of their choice. So we would assume that video would represent their best performance. And basically, the research team edited those videos to make them manageable. And around 10 sort of surgeon raters rated those videos using an assessment tool called OSAS, which is an objective structured assessment of technical skills. And outside of OSAS, the research team also looked at the complication rates of these 20 surgeons. Now, this Michigan collaborative group, they have a very large database for surgeons and for the patient outcomes, etc. This was doable for them. And ultimately, they found what we always assumed. There was a really strong correlation between the way a surgeon, the score that they get in their technical skills and their complication rates. And do keep in mind that surgeons submit what they assume to be their best performance. And to have this kind of a relationship is, I think, a strong statement. But I think, when we think about procedural skills and what makes a good physician, what makes a good surgeon, what makes someone perform in an expert manner when it comes to procedural skills, I think to answer that question, one of my colleagues who was at McGill at the time with me, Dr. Amin Madani, we worked together as graduate students, but he was a resident at the time, and he's currently at University of Toronto as an assistant professor at UH. But ultimately, he wanted to answer just that question. But what are the skills or domains of skills that we need to look at that are important when we are looking at procedural skills? And he created this sort of diagram, you can call it a framework, but ultimately he identified 5 key domains or 5 key skills that are important and that a physician needs to expertly and competently perform in order to be an expert of that procedure itself. But he identified 5 domains. These were psychomotor skills, declarative knowledge, interpersonal skills, personal resourcefulness, and advanced cognitive skills. And as you can see in this diagram, these 5 domains span across the non-technical skills and technical skills, which is not a black and white spectrum, these 5 skills are important. If you miss one, then you can't really be considered an expert surgeon or expert physician in that procedure because you need all of these 5. So they are very much linked together. Now I'm going to go through each of the 5 because I think that's very, very important and key when we think about any procedural skills or any procedural skills training and assessments. The first one is psychomotor skills. I think this is the one that in the definition that I mentioned before has been the main focus. It's about really coordinating various physical and these motor skills, and you turn these into these like sequential patterns, and ultimately you try to perform a task. And these tasks can be retracting a tissue, suturing, things like that, simple manual skills. And as you can see at the bottom here, technically this psychomotor skills is a major component of technical skills. It's not the only thing, but when we think about technical performance, a lot of the time we think about psychomotor skills, which is true, but there is more to it than just one domain. The second is declarative knowledge, and this is more about these facts that you learn outside of the procedure itself. So we can look at it, and I guess we can divide it into 3 categories. So one is about knowing the anatomy, physiology, pathology for the relevant ones related to the procedure that you're doing. Second is knowing the procedural techniques themselves, knowing the steps, knowing the pitfalls, knowing both the unplanned and the planned versions of that procedure, of the techniques that you need. And also the pitfalls, because every procedure tends to have various pitfalls along the way. And of course, it also has quite important decision points. This is again true for across any procedure, really. And also, it's also an important factor that we have to know the literature, the evidence behind why we choose to do certain things. And that's very important for patient management itself. Like why what are the different complication rates? What are the risk factors for the various adverse events? Because at the end, that's going to potentially determine how you approach that procedure, but also the post-procedural management. Third is interpersonal skills. This is basically focusing on the fact that a procedure is not done alone. You have a team, and you need to be able to coordinate the multiple team members in order to successfully perform a procedure. Now, again, you can look at this from 2, I guess, sub-themes or categories, however way you want to call that. But the first one is teamwork, communication, and cooperation. The idea here is that you have to be able to work collaboratively. You have to be able to share information. You have to really understand your team and your team's dynamic in order to successfully complete that procedure, which is always the end goal at the end of the day. And the second point is leadership and management. This is more about, you have to be able to manage your team. You have to be able to, again, share that knowledge, share that environment, and make sure that you are at the end completing the procedure successfully, keeping in mind that you have a team who might be diverse in background, diverse in skill level. So you have to be able to manage your team accordingly. The fourth domain is personal resourcefulness. This is more about your own self and being able to regulate your thinking and your behaviors, keeping in mind some of the factors that might actually impact why you do certain things at that moment. Those can include physical factors. You might be fatigued, there might be some physical impairments, or just anything really, but those physical factors do matter. The second point is psychological factors. Now, it might be about your confidence level that you have, the certain beliefs that you carry, the motivation that you have, but also fear of error. If as a physician, you have certain fears that might impact how you perform, and at the end, your team's performance as well. Also, social factors. If you're so worried about your reputation, that might have some impact. Also, if you have, let's say, family issues or various professional issues, maybe I shouldn't say issues, it could be both positive and negative, but those can all impact how you perform in a procedure. And time pressure as well, especially in surgery. Your next case might be canceled if maybe the case you're doing now took too long. So then you might actually have to take over from a resident's teaching opportunity to perform that procedure fast so that you can go to the next procedure. So I think all of that do play an important role in how you perform a procedure. Now, as you can see, I think the last two that I mentioned are leaning more towards that non-technical skills side of the continuum. But again, these all overlap. They all kind of sort of come together at the end. Last but not least, advanced cognitive skills. I think this is something that is particularly important, I find, and it's one that a lot of training and assessment don't necessarily focus on because it is complex and it is hard to really capture all the different skills required for this one domain. Now, advanced cognitive skills are meant to be more, you have this knowledge, this hidden knowledge, this past knowledge, and you have this higher order thinking that at the end reflects your behavior and your actions in the operating. So we can divide this into two components. The first one is surgical planning and error prevention. This is actually the majority of this domain. Basically, the idea is that these are the routine decisions that you make in a procedure, both planned and unplanned. If there are complications that happen, certain errors that might have happened, but ultimately this is meant to be, are you able to make certain decisions to be able to complete that procedure successfully while still handling the complications or being able to prevent certain errors by thinking ahead, let's say. The second one is error recognition, rescue, and recovery. And this takes a smaller portion within this domain, but especially true in emergency cases where a physician is not able to necessarily understand where that error or that injury or that adverse event might come from, that might actually require that procedure. So being able to handle that recognition of that error or that injury and being able to fix it in a way is an important component of this bigger picture advanced cognitive skills domain. As I said, this is probably, and as you can see in the diagram, it takes up more space than the others because it is more complex. And it does have pretty several components to it. And the way I tend to see this is, psychomotor skills, declarative knowledge, and the other two, those are almost like foundations in a way. But for advanced cognitive skills, it's something that you build with experience, with time. So that's why it's harder to train and assess people on this, because it is a lot more complex. And now I wanted to give you an example using this diagram of these 5 domains that are required for someone to be an expert or perform in an expert level. I did a study that we wanted to understand what are the key skills that are important when performing in advanced laparoscopy surgery. And I think you will see, I'm just going to give 3 examples, but you will see how these skills that I've identified really relate to those 5 domains. And the first one is, the theme was thinking multiple steps ahead. And the quote said, as soon as I see something that might lead, I will generally think to myself, what do I have open? What do I have immediately available, but not open, that can help me should I start thinking? Whereas I think that residents start thinking about that after, especially. I think this comes back to the idea of that domain 5, the advanced cognitive skills, the idea of being able to think multiple steps ahead and be able to prevent an injury, prevent an error, prevent a complication, and act accordingly. Another example is knowing the limitations of your surgical care. Example, their experiences in the procedure, their experiences working with the other team members. And something like that could be a bit more of interpersonal skills, where you have to really understand the team and manage it accordingly. Final example, suturing during complication. Now, if you look at this, I think this has two components. One is being able to actually perform suturing, which you can think of it from a psychomotor skills perspective. But I think where this theme and these codes really come into play is more of that advanced cognitive skills, performing these more complex techniques, complex maneuvers, when you have certain, complications, deviation from the normal set of courses. So hopefully I was able to give you a brief overview of the domains of skill that are important for procedural skills. I only gave you this example because for me, it makes things a lot more clear when I'm thinking about procedural skills and how to train and assess residents on them. But I want to give you some of my examples with procedural skills, and I think what you will see is that my main focus so far has been more on that technical skills side of the spectrum, and I think this is where I will really dive into some of my surgical education research. But I think around 20 years ago or so, as laparoscopy was being introduced into the practice routines of physicians, of surgeons, surgeons were learning it for the first time, but at the same time, they had to help residents learn those techniques, those skills required and perform laparoscopy. And that was very new because that wasn't a part of the residence curriculum. So at McGill, but it was of course a collaboration, but specifically at McGill, they really worked hard on developing manual tasks that could be used to help trainees gain some of the foundations or fundamental skills required to perform these laparoscopy procedures. And I would say residents, but also really anyone who was starting out in performing laparoscopy. It doesn't have to be trainees, could be attending physicians as well. And just as an FYI, I am a FLS committee member, so I did do some work with them as we were looking at FLS and how it functions, etc. But this has both of a training module, but also an assessment component to it. But certainly manual skills do play an important role. Now, the thing with laparoscopy was that as time went by, currently, for instance, there's a lot more procedures being performed laparoscopically, but also a lot more advanced procedure, maybe complex procedures, you could say. So with these evolving needs that came with these evolving practice routines of physicians, there were quite a few needs assessments done, including some from our lab as well, as we wanted to really understand what are some of the key skills that are important with performing in laparoscopy. And as a result of some of the needs we identified, we developed these tasks that were hopefully better representative of the complex skills required in the clinical setting. In a way, this was a step upwards from FLS and the skills that were targeted there. And we used, inanimate models, we used benchtop simulators because that worked for the skills that we were targeting. And because it was laparoscopy, benchtop simulators worked quite well. So we didn't need to use more higher technology simulations, etc. This inanimate models, simple sort of lower cost simulators did work quite well for helping residents gain some of these a bit more advanced laparoscopic skills. Now, I think no matter what, the point of simulation is always, can we improve a trainee's clinical skills, right? That's always the point, is that transfer of learning. So we took on this research with partnering with University of Toronto, Dr. Elif, who's a surgeon at UHN. And we wanted to really understand if we use these advanced laparoscopic suturing tests that we developed, can we improve a trainee's skill level? And we focused on senior residents because these sort of skills target senior residents, as they are the ones who are more and more exposed to these more advanced skill sets. And we did find positive results. There were trends that training did improve their skill level in the operating room. We can't really conclude anything because of our sample size, etc. But I think we saw some good trends. And as I mentioned, of course, clinical setting, I mean, if you look at even just Royal College and EPAs, a lot of the time, EPA assessments happen in the clinical setting, right? So being able to assess individuals in the clinical setting, not only assess, but to train residents in the clinical setting do play, a major role outside of simulation use as an adjunct or almost like a preparation for the clinical setting. So some of my work really evolved around how can we better assess residents in the operating room. Because what we found from the literature was that for any given procedure or procedure type, there were a lot of assessment tools out there, right? I think researchers were just developing assessment tools, and I don't always know why, but they were just developing them. So we first wanted to really understand what is out there when it comes to assessment tools, and what can we use for our own purposes, for our own population, for our own context. And after that, another thing that was important for us is, let's say we found one assessment tool that we could use based on, again, our own institution, our own sort of objectives. But how many assessments we would actually need to perform to make sure that we are capturing the skill level of that trainee properly? And I think, again, that's always an important question is one assessment enough? Usually not. We need multiple assessments. And that is why, even with all this, CBD and EP assessments, the main encouragement is these frequent assessments, because it's meant to, create, multiple snapshots so that hopefully at the end, we are able to get a big, better picture of someone's skill level in that procedure, in this case, but that skill at the end. And another thing that, we want to look at is, I was a part of the study where we wanted to use short segments of operative videos to help train and assess trainees on some of the decision-making skills that would be required in a procedure. And I think this is more in line with that advanced cognitive skills training and assessment, whereas the other one was mostly technical skills, mostly psychomotor skills. And yeah, so, again, this is a work by Dr. Madani, and we just sort of developed this interactive tool that could be used as a way of helping trainees learn or assess their skill level when it comes to making certain decisions during a procedure. And when I looked at pediatrics specifically, I'm more just looking at the procedural skills and sort of what is being done so far. And the bottom article is actually quite new. And they're all sort of mentioning or concluding the same thing, and that is that we have certain procedures that we deem as important, but a lot of them are infrequently performed. So residents don't actually get the exposure necessary to be competent or to even be able to be assessed in these procedures for general learning, for EPA assessments, however that may look like. But there's definitely a need when it comes to procedural skills and what is the important versus what is actually what kind of experiences are available in a training program. And I think that leads to my sort of final stage of my presentation, which is current and future opportunities, because we understand some of these needs, not only just current needs, but evolving needs as techniques are improving, technologies are increasing for simulation, but also clinical setting. So what can we do to try to improve training assessment when it comes to procedural skills through within both simulation and clinical setting? I think the first one that is, I think, important to consider, we have CBD by the Royal College. And when I did my CIHR work, what we found is that, and I focused on EPA assessments and trainees and faculty's experiences within perceptions about it. But we identified, I guess, three big domains of challenges. One was more about the logistical challenges that came with the actual, logistics of getting assessments. The second was more psychological challenges that really was impacted by the logistical challenges. But then the third was more about the bigger picture Royal College related challenges when it came to the EPAs and EPA assessments and the rules around them. And that's why I think there is a lot of room for research and further refinement of some of these challenges that we identify that residents and faculty are facing. And just to give you one example, right? If you look at this EPA number 7, which is about basic pediatric procedures, something that I have sort of put in a square in green here is these procedures, or some of them, can be observed in the clinical or the simulation setting. However, when I look at the literature, but also talking to some of the faculty in pediatrics here at Master, outside of pediatrics in general, like talking to some people, I know that simulation isn't used much, if at all, when it comes to these forms of assessments. But I think there's, as I said, a lot of room for using things like simulation as a part of assessment, but also training, especially in procedures that are not frequently encountered within a residency training program. I know, like as I said here, my work mostly focused on benchtop simulators, just because that was the for laparoscopy worked quite well with inanimate models. But there is a lot more types of simulation models that we can use. We can use more full body methods. We can use part-based trainers, depending on our objective and our population, etc. But one area that I think could be important to or valuable to look at is virtual simulation, because even if you just look at Royal College EPAs, they don't specify what type of simulation you could use. And virtual simulation, I think there's like mixed opinions about virtual simulation and its value, and I do understand it. But on the left side, I did some work with a virtual simulation company during my postdoc. It wasn't for procedural skills, but what I found is that it does have some value, and it could really be used as an adjunct to the clinical setting, but also instead of physical models. I know maybe a bit more research needs to be done, especially with procedural skills where the haptics are not there. Of course, that causes some problems, but there could be a big role. I mean, in laparoscopy, there are quite a few virtual reality laparoscopy simulators. As I said, even for those, there are quite a few mixed feelings about it and about its usage in the training of residents. But I do think there is value in investigating this further. Another thing that actually is an interest of mine, I would say, is video-based assessments. Now, in surgery, it's a lot easier to record videos, especially for minimally invasive procedures where you can just record what's seen in the camera. So there are less issues of seeing the patient or seeing the surgical team members in terms of just legal ethical concerns. But I think it's used a lot less, or is taught a lot less in non-surgical specialties, probably mostly because it's a lot harder to record a video of a real clinical encounter without recording the patient's face, or the patient and the physician and other team members. And that creates a lot of complications from an ethical standpoint. But even for simulation, I think there could be quite a bit of value. So when I came across this paper, which was published not too long ago, I really wanted to understand the perceptions and experiences of both the trainees and the raters when it comes to direct observation versus video-based assessments. Now, for this study, like for the video recording itself, they actually implemented cameras that were not a part of the simulation center. So they implemented cameras from different angles to try to see, what would be the best sort of angle or best angle to help raters assess the student. And what they found is that when you compare scores, they're similar. I don't think the score itself is different, but what is different is in direct observation, the rater can see a lot more, whereas in the video, they are limited by the camera angles. And this specific study included both procedural skills and non-procedural skills. I think especially for procedural skills, the raters did comment that we would love to see the details of how they perform certain things to be able to accurately make decisions about someone's skill level. But that's just one example. So I do think there's a lot of work that could be done to try to understand how actually a rater makes a decision from a video versus direct observation, because I think that would be valuable, but also really the logistical factors to consider. And here you'll see these two examples on the right side. They're actually they're not from the website of our sim center, but they use the same learning space. So these cameras are already improved in our simulation center. This is sort of the images that you see, and anyone can see those images, like the different angle video recordings, the vital signs available, you can annotate, etc. So that learning space where videos can be recorded, downloaded, annotated, etc. is already there. But as I said, I think we just need to really focus on what would be the best use of videos and really make sure that when we use videos, it is really capturing that performance of the trainee compared to more direct observation. And I will say, again, for the EPA assessments, I saw that it's all direct observation. They don't have a video-based assessment component. I'm not sure why, but of course, as I said, there are limitations to video-based assessments that probably played an important role in that decision, but there is merit to investigate that further. Finally, artificial intelligence or AI. Now, I've started to explore this further as a part of my last postdoc. And we wanted to just get a sense of what has been done so far when it comes to health science education and AI, and what is needed. And there are a couple of things that we identified that I think we need to really explore further. The one was, obviously, medical education itself is an interdisciplinary field, but a lot of the time, the researchers were from a single discipline. Let's say they were from cognitive science or engineering, while they were developing an AI algorithm for assessment of training performances. So I think we really have to be cautious and careful, and really, if we are gonna develop AI techniques or implement AI techniques for the sake of improving the education of our trainees, we have to have this interdisciplinary group of individuals who understand, yes, the technical aspects of it, very important, but also the educational aspect of it, the medical aspect of it, the ethical, legal aspects of it. So I think that's why we do need that more interdisciplinary approach to it. I also saw that a lot of the studies focus on performance assessment, more specifically comparing expert analysis. And I will say some of the articles were even not clear on who a novice was versus who an expert was. So that's also something where a lot of authors called for future researches. How can we really use AI as a more feedback generating, feedback giving tool, more like a regular instructor? But I think we are a long way from that. But I will give you an example. I think that will be nice to see that there is work being done in that aspect of AI as well. But even just within performance assessment, there were quite a few limitations, especially with the data sets that people were using. They were either really small, really sort of not diverse in terms of the skill level, and then the scores that on the videos that the researchers had to be able to apply or develop AI. But I will show you this very quick example. It's actually from one of McGill's neurosurgery lab, led by Dr. Bilgic. Now, he has done, and his team has done a lot of work with AI for neurosurgical education. They have a virtual reality neurosurgical simulator, and they have just focused on that simulator and really tried to apply different AI techniques or explore different AI techniques to for both assessment purposes, but also again in that training, that feedback generation purposes. And this is just one example, relatively recent. Is they did a study to figure out if AI tutoring compares to expert tutoring. This was more where the AI gave feedback after the performance, and then the student took that feedback and then redid that task until they reached a certain benchmark. But I know that they're currently now working on more live feedback as well, verbal live feedback. I know they're just starting to study, I think, for that, but there's definitely some progress, and I think Dr. Bilgic's lab especially has been doing a lot of work. And of course, with VR, you get a lot more metrics. There's a lot more flexibility when it comes to the metrics that you have and videos that you can sort of record and use, etc. But I'm sure in the future, VR, other simulations, we can definitely see AI being really implemented or studied for those purposes. So in summary, I think we really have to look at procedural skills from different lenses, not just from a psychomotor lens, but from, I think, these 5 domains of expertise or that competence that really set the tone for what a physician needs if they want to be to perform in an expert manner. And I understand that in surgery, of course, procedures are maybe a lot more complex, a lot more longer in duration compared to some of the other specialties. But I think a lot of these really hold true when we think about procedural skills in any specialty. And I hope that we would be able to use different strategies to be able to target these domains to provide the best and optimized training for our residents. Thank you. I'm very happy taking questions.
Thanks so much, Dr. Bilgic. I'm familiar with a little bit of that work on AI from McGill. My anecdote, of course, is that they use a supervised data set to show proof of concept with some of their ML models, which misidentified at least one of their attending surgeons as being a junior trainee, which I think may not have been a misidentification. That's my punchline. I am curious to know how you recommend procedural skills training in a simulated fashion. And the background is a number of our investigators here have conducted a large study where we used mastery learning as the model, where we deconstructed all the pieces and had them sequentially acquire skill at the foundational, intermediate, and then advanced steps. But when we compared it to a traditional spend time in the simulation lab and ask an instructor for help when you run out, we didn't actually see any benefit except at retest at around 6 months. But immediately post training or educational intervention, and 1 month later, we saw no difference in equivalence, even though the intervention was harder to use. Any thoughts on the best ways to teach in the simulation lab to maximize time? Our study didn't show what we thought was going to be the superiority of a mastery learning process.
No, I think definitely, thank you for the question. And I do hear you. I think there are quite a few studies that do show that even though mastery learning or deliberate practice is maybe a bit superior in terms of the training method itself, but at the end when we look at retentions and even just sort of short-term outcomes of skill gain, it's not always clear, and it's sort of as a mixed results, mixed messages. But no matter what, I think there is a lot of value to target procedural skills training assessment from a deliberate practice perspective. Really, and that was sort of some of the work we did with FLS or laparoscopic suturing, was more that we wanted for residents to be able to have various benchmarks to target, but then go for more basic skills and go more towards advanced skills. And again, use those benchmarks as a way of training. Now, I no matter what, I think that adds a lot of value than giving someone some time in the simulation setting and just telling them, do this and get a maybe certain score in the simulator, and that's about it. I think it would be nice. I'm not sure if you guys look at sort of trainees' experiences with that kind of a training environment, but I know that at least from a speak literature, one of the major limitations of simulation training is that it's hard to find instructors, but it's also hard to find instructors who know how to do those kind of specific skills. And that has been one of the major limitations with creating these simulation opportunities, yet alone creating these opportunities where people can have a little bit of practice and sort of retention and training every couple months, right? I think that's always an issue, but I do think that that deliberate practice or mastery learning approach could be still very valuable. And I will say something that came up in our AI virtual panel that we did was that if AI techniques can be developed well enough, and I'm not saying it's there yet, but in a way it could even replace human instructors and be used as a more flexible, adaptable learning environment, so that we don't actually need the presence of instructor, and all of those deliberate practice concepts can be already implemented within that simulation. So that's sort of my thought. Maybe others have different thought processes, but that's how I'm thinking about it.
We have a question, 2 questions from the virtual audience. So Teresa asks, do you think we have too narrow a concept of what is a procedure? Some argue that communication with patients is a procedure, or running a department. Thoughts on this?
Yeah, no, I think that is a good point. And that's why I wanted to give that definition at the beginning to try to orient the audience, just everyone in general, to what I have what I am referring to as a procedure. So, for me, if you're thinking of a procedure, it should include those 5 domains. And I guess in a way, you can really use those 5 domains to define what is a procedure, but then also make sure that people have the necessary expertise in those domains to make a good physician in that procedure. So I hear you, but I think using those 5 domains as a reference point could be an important differentiation of how people perceive as one procedure versus another type of procedure.
And another question here. I'm curious about the evidence surrounding best practice for teaching and assessing the interpersonal skills component of procedural skills training, whether through direct observation or simulation setting.
So, my main sort of focus so far has been more on the technical skill side, but I do know that I'm going to refer to this as non-technical skills for the sake of the conversation. But I think there are quite a few, let's say, assessment tools out there that are used, let's say the non-technical skills assessment, etc., that are meant to target these more non-technical skills components of a procedure. But also I know even just within EPAs and sort of the decision-making points, communication skills, those kinds of non-technical skills do play an important role in those like entrustment decisions are an important, communications, etc., are an important part of that entrustment decision. And sometimes, again, this is more of a my own observation / assessment, maybe not necessarily answering the question in that sense, but when we look at even technical skills and how someone is performing the technical skills portion of the procedure, I do think raters might be looking at those more non-technical skills aspects of it, even though it's not directly assessed, that might play an important role in even just the technical skills component. But yeah, I think a lot of times it's more direct observation and usage of like the non-text, like those kinds of very out there sort of assessment. But I haven't really, and I think when it comes to simulation setting, I think one of the main limitations of the simulation setting and procedural skills and being able to target multiple of these 5 domains is the fact that you can't really do too much of a procedure in a simulator. It's quite limited. You can do like resuscitation or something, but like there's not much you can do when it comes to procedural skills. And so it's actually quite difficult to train and assess residents for both procedural skills, but also, for both the technical skills, but also the non-technical skills that are associated with those, that overall procedural skills performance, because we can't really assess them on how they perform procedure, let alone how they interact, how they communicate, etc. So usually in simulation, that is done separately. Like you don't combine them. Non-technical skills, they are assessed sort of in their own world using. I'm going to use it as a quotation, high fidelity scenarios, and I don't necessarily like that word, but we can call it high fidelity scenarios where it's just focusing on those more decision making, not technical skill aspect of things. But I haven't really seen a simulation assessment where it's combining everything, all the domains into one simulation.
Do you think that's a problem? Like, is it possible to assess those different domains in separate settings? Or and if it is a problem, what in your mind is the solution to that? Like, what would that look like? And what do we need to know, or like what kind of technologies do we need to have?
So I think that's a really good question. Something that a lot of people who are looking at procedural skills have been talking, maybe I should repeat that, Renata is just asking, is it a problem that non-technical skills and technical skills cannot be assessed in the same, let's say, in the same simulation scenario? And maybe hopefully I'm saying that correctly.
Yeah, or potentially taught together.
Or
right?
taught
Like,
together,
the
right.
assessment and teaching are both divorced.
Right.
I wonder if they get the whole task.
Exactly. And I think there are different ways to look at it. First, when we look at more, I guess, as a PGY 1 or 2, like junior residents, it's always good to separate things because they only have so much capacity to learn. So I think that's why we have specific scenarios for, let's say giving bad news, etc. Not that that's, I would consider it as a procedural skill, but I think the idea is we're separate. And then they're learning the psychomotor aspects of things separately, like using some of those simulators that I mentioned. But I think the combining those is a bit more complex. And that's why I think I briefly mentioned it before, that for some of these more complex skills, maybe simulation might not necessarily be the right approach, because I think those complexities, now that we helped trainees gain the psychomotor skills and the other non-technical skills, and now they can use their time in the clinical setting to actually, in a way, combine what they have learned and interact with the patients and with the procedural team members. So, but it's also about the fact that we don't really have the current technology in, like, I haven't really seen, maybe outside of virtual reality, but that's usually done alone, at least for procedural skills. I haven't seen the technology there yet to be able to combine those. But I do think no matter what, maybe the initial learning curves, we can look at it separately, but as things get complex and we look at the procedure as a whole, clinical setting might end up being the right setting to help trainees gain some of those more complex skills, combining the two. Thank you.
So Dr. Bilgic, let me thank you for rounds. Let me welcome you again. Thank to all who joined us in person and virtually. Please consider joining us June 8th at the NERD Day, which is a very apropos acronym for Norman Education Research Day. Take care.